TV or any other form of newspaper sometimes, is just not the same as hearing it from a congressperson, so thank you. But my concern is the cost. It's why now. It's our deficit. I mean, it's our country's future. And Dick Durbin was on the Senate floor. I saw him say, yes, your premiums will go up, but not as much. And we're talking Medicare recipients also, which I'm 2 years away from, and concerned about it. I mean, I saw my mom when she was ill for about a year and a half, similar to what your dad and you went through. But waiting 8 hours, 10 hours in a hallway. And when I asked the doctor about it, I said, I'm a baby boomer. What's going to happen to our group? And he goes, honey, there won't be Medicare left. Now, this was 4 years ago. So when you hear that it's solid and it's sound, I mean, I've heard that the money that you're going to save is going to go towards Medicare, Medicaid, because states are broke. I mean, I can just go on and on. I feel like I'm exploding right now, so forgive me.
You're sure
trying
a lot
to follow
of concerns.
Me, but it is.
A lot of
it's
concerns
true.
people have.
It's like, I mean, the future is now. And again, these are things in the past that should have been taken care of. They haven't. And so now we're paying for it. So,
well, I guess to answer your question about so why now,
yes.
I think if we're going to get our country back on a path of fiscal responsibility, healthcare has to be part of it. Because that has been eating up more and more of overall American dollars and the federal budget. So when you look at it as the fastest growing portion of our federal expenditures, if we don't get it under control and we don't start moving in the direction to electronic patient records to eliminate errors and redundancies, if we don't move to coordinated care, so doctors are working together in a way that really improves outcomes, when we're leaving it up to the memory of the patient, when they travel from one person to another about, I think this is what I had, and I think this was what my last doctor said, and that's where this next doctor's starting up. It's not the best way forward. And so, particularly with the aging demographic in our country, the longer we wait, the bigger the problem gets. I mean, when you consider how much we're paying on interest on our debt, we really did have to get moving. It's not the only thing we're doing given the economy and other challenges with revenue being down that even exacerbates the challenge. But when we're spending twice as much as the percentage of GDP of other industrialized nations in the world, we know there's vast improvements that can be made to our system, particularly when there's so many advantages to our system, and that we have the best doctors, we have the best technology, we have the best medical schools, and it's been an issue of how we distribute that. So this bill does have some savings. We talked about the $500 billion overpayments and waste and fraud within the system due to duplicative payments, but those monies are being used to extend the solvency of the program. And while there are costs up front investing in primary care so that we can cover the new populations of people that will now be coming in for services, the reality is at the end of the day, this saves money. And so it's $138 billion in the first 10 years and $1.3 trillion over 20. So I think when you do look at that, you do have to look at not just the upfront cost, but where those savings are realized. And by the way, I looked very closely at the CBO scores. There were a number of the things we've just talked about that didn't even score. Because they haven't tested them widely yet, they couldn't score them. But the anticipation is that there will be great savings in some of these areas, but they didn't have an actual referenceable point to look at, other than some domestic examples right here that have been successful. If you look at the coordinated care efforts at, say, Mayo Clinic or Cleveland Clinic, there are some great examples of how they, per patient, yield better results at lower costs. But moving that from some organizations where a high percentage of their doctors are part of the hospital system to those that aren't is part of the transition of how do you take best practices and move them across a system that's very diverse in how we actually deliver care. And so those are the things that we're challenged by. But I think you raised good questions. I'm pleased with from where we started in the House bill, which that I supported that bill. At the time that I supported it, I had said at the time, well, I'd like movement to electronic patient records, but I'd like that we're moving to quality metrics and not just fee for service. I still had concerns about where we were headed in terms of the cost curve containment. But to your point, it is important that we don't misset expectations, that people think they're going to see their premiums drop overnight. That's just not going to be the case. But what we've already seen is double-digit increases year over year. So that's not going to change immediately, but what we can start to see is the curve and the percentage of increase will come down so that it will become more manageable for more people. The point being, by bringing more people into the pool, we spread cost and risk over more individuals, and everyone shares